Our last talk of the meeting is a twofer. So we have Maya and is it Carlyn?
Carlyn, yeah.
Carlyn from CHOP. They will be discussing the CARS and autism findings in the STAR study.
Thank you. Thank you. It's a pleasure to be here, and we understand we are the last talk between everyone and the weekend, well, the roundtable. But like Jim said, my name is Carlyn, and I'm here with Maya. Today we'll be talking about the CARS, the Childhood Autism Rating Scale, profiles in children with STXBP1. So just to start out with, I would like to briefly define autism. Broadly, autism is a pattern of behavior where we have delays in social communication and social interactions, as well as behaviors that serve a self-regulatory purpose. These can look restrictive or repetitive in nature. Now, within the context of STXBP1, we've come to understand that many individuals don't necessarily fit this classic picture of autism. They may actually show relative strengths in their social motivation. Yet the way they engage with verbal and nonverbal communication for social purposes can be both delayed and different than we might expect. The clinical phenotype of STXBP1 includes, among other features, autism or autistic traits. And in working with this population since the inception of the END clinic, I have come to appreciate that autism does not always present in the textbook way. As such, autism can be misunderstood and often isn't diagnosed or addressed adequately. For many young children with STXBP1, the impact of gross motor skills, gross motor delays, cognitive delays, this is really at the forefront of our attention, and rightfully so. It drives the therapy. But this can lead to social communication and social interaction differences being overshadowed or overlooked. Furthermore, like I mentioned on the previous slide, some STXers may actually have relative strengths in their social communication skills, like using eye contact to communicate their needs and social interest, and this can really muddy our autism evaluation. Undiagnosed autism can lead to delays in accessing appropriate and timely care. So it's crucial that we really gain a more comprehensive understanding of what autism looks like in these individuals so that we can confidently provide a diagnosis when appropriate. Diagnosing and treating autism in individuals with intellectual differences is a long-standing challenge. Previous research has shown that individuals with a lower IQ is actually associated with an increased risk or rate of autism. But severe intellectual disability really complicates valid assessments of certain autism symptoms. Most diagnostic tools used to evaluate autism assume a minimum cognitive level of about 24 months, the CARS, for example. So many individuals with STX have not yet reached this cognitive level. So these tools are really not ideally suited for this purpose, but they're all we have. At certain developmental levels, we know that sensory-seeking behaviors and other repetitive behaviors are appropriate and even expected. But as children mature cognitively, we also expect that these behaviors start to dissipate. So while they're often universally reported in individuals with STX, we really do need to interpret them relative to cognitive level. Similarly, we have to try and identify relative deficits in social communication and play. So we're really looking to see that social communication differences cannot be explained by a delay alone. I'm going to turn it over to Maya.
So, the goal of the present study was to assess autism symptom severity in individuals with STX using a gold standard tool, the CARS, which we discussed, and to characterize the social behavioral phenotype in our population by identifying core characteristics of autism that, based on clinician confidence, that we feel are specific to this population. So You've heard all about the STAR study. So our participants were part of the STAR study, and we used the CARS for every participant who comes through to assess for autism. And so for the purpose of this study, we did a chart review. We looked across all STAR participants to determine autism diagnostic status and characteristics of past and current individuals with STX. And then also novel data collection using a modified CARS, which I'll discuss in a moment, which we created to assess for clinician confidence and factors affecting confidence, which I'll go into more detail shortly as well. So for those unfamiliar, I know the CARS has been touched on briefly, but as I said, the CARS is a gold standard assessment for assessing autism in children. It's completed by clinicians based on either parent report or behavioral observations or both. And there are two versions of the CARS. The standard version, which the vast majority of our individuals is what we used the standard version for, which is for children 6 and under, and for those who are 6 and older, but who are minimally verbal or who have an IQ lower than 80. And then there's the high functioning version, which is for children 6 and older who have fluent speech. And then, so you rate participants or individuals on 15 items, and that culminates in a total score, which corresponds to a severity score, minimal to no symptoms of autism, mild to moderate, severe. And then you also get a T-score, which actually compares the individual to other children diagnosed with autism. So then just a closer look at the 15 items. We rate all of these items on a scale from 1 to 4. 1 is no evidence of differences, and 4 is significant differences, and they're actually half points as well. Higher scores indicate more noticeable characteristics with greater interference in functioning. And very briefly, a lot of these items, as you can imagine, correspond to the diagnostic criteria that we talked about, which I won't go through right now, but if you have questions about, we can go through in more detail later. There's a lot of items. All right. So then we created a modified CARS. So what we added was a cover page where clinicians can document whether the child already has an autism diagnosis from the community when they came into our clinic, whether a diagnosis was made or confirmed at the current visit, and whether, and overall confidence in that diagnostic decision, as well as factors that we felt might be impacting their confidence. We assessed confidence levels based on a 4-point Likert scale, 1 being very confident, 2 moderately confident, 3 somewhat confident, and 4 not confident. And we assessed both overall confidence in diagnostic decision, as I mentioned, as well as confidence per item. And so then for each item, we got a little snippet here of what it looks like. We also, if confidence levels were greater than 1, so if you were anything other than very confident, we asked you to rate indicate what factors you felt were affecting your confidence. And clinicians could select as many factors as they felt were relevant. And the factors that we included were developmental or cognitive ability that does not meet the requirement of 12 months of age, which was a designation we set, since, as Carlyn previously discussed, many of our individuals don't even reach that 24 months of age, developmental age, so we set the criteria at 12 months. Significant motor impairment, significant or undetermined visual impairment, seizure activity during administration, recent medication changes, or other, if there was another reason that we did not include. And the reason we really wanted to include this confidence piece here is because after, I think I joined the team, and there had already been doing a number of CARS on individuals, and it just felt like, the way the measure was created, it was not built for our population. So the ultimate goal was to try to see if, based on confidence, we could find a subset of items that felt more relevant to the behavioral phenotype specific to STX.
I think they were tired of me writing, "I don't like this measure" on the top of the cards. So what came next? We have some results that we'd like to share. So we looked at the charts we did a chart review. We looked at the charts of 104 STXers who have come through our clinic and found that though not all have a diagnosis of autism, they all have autistic traits. We also noticed that almost all have repetitive behaviors and that they engage in sensory seeking behaviors. Those who do not yet have a clinical diagnosis of autism usually appear to have social skills in line with their cognitive skills. In other words, their level of delay across these domains is not discrepant. So in individuals with autism, we usually see a discrepancy between social skills and cognitive skills. So here's just a comparison, and what I'd like you to focus on are the first 3 columns and then column number 4. So when we took a look at the literature, we noticed that large cohorts show variable diagnoses of autism in the STX population. In the literature, that first column there, the prevalence of autism and autistic features is surprisingly low. That second column features larger cohort studies. There's a slightly higher prevalence of autism and autistic features. When we're looking at records, we see yet slightly more. And then when we look at our modified CARS data, that fourth column, wow, it looks really discrepant. We see almost everyone has autism or autistic features. So why this discrepancy? And that's what we're really trying to better understand and get at. You know, there could be several likely factors that come into play. One being simply convention is not to diagnose children who are cognitively less than 24 months. You know, and certainly not diagnose them at a cognitive level less than 12 months. That affects the number of children who receive an evaluation and subsequently a diagnosis. As we've mentioned before, many of the participants that we see in clinic, when we see them, don't yet have a developmental level of 24 months. But they often have behaviors that may be impacting functioning. So we do believe that these children should still be evaluated. And you know, this could be as simple as we're evaluating all of these children who come through our clinic. We're evaluating them every time they come through our clinic. We're picking up more of these autistic features, you know, with this modified CARS.
Yeah, and just to clarify too, we're trying to make the distinction between autistic features and autism diagnoses, because we do still believe that some children may not be at the appropriate developmental level to receive a diagnosis, and we're not necessarily advocating for that, but we are saying that even in those children, by doing this assessment, we're identifying that there are still autistic features, even in children younger than, with developmental ages younger than 12 months. But then over that age, we feel like there may be more of an argument to be made for doing these assessments, potentially to diagnose as well. So this next slide, now we looked at, this is the raw data of the confidence, clinician confidence ratings that we talked about from the modified CARS. And specifically, we started by looking at confidence by chronological age. And I think the green is very confident, so it's clear here that the x-axis there is chronological age, and as kids get older, clinician confidence increases. Pretty clear picture there. More relevant to our central sort of idea and theme here is looking at confidence by developmental age. And here, the picture is still generally that across there, the x-axis, now we're looking at developmental age in months. As developmental age increases, generally confidence of clinician increases as well, especially if you collapse across those two right bars there. And this is in line with our clinical impressions when we first went into this project. So this is starting to sort of support our feeling that by about 12 plus months, we're feeling more confident in a number of the items and our diagnostic decisions. And then lastly, we're starting to look at clinician confidence by item. So this is collapsing across aged, chronological, and developmental age. And here we're just looking at confidence by those 15 items. So we've put it in order from left to right, from items we were most confident in to least. So there's more green starting in the left and the least amount of green going to the right. And with regard, and this really is where the variables impacting those variables that we talked about that might be impacting our confidence kind of start to come into play. But with regard to some of the items that we were most confident in, if you look, verbal communication is one of the ones we're most confident in, which makes sense. I think that stands out for a lot of our individuals. A lot of them are nonverbal, but also we're seeing both differences in their use of language, but also some differences in just the verbal oddities and reciprocal interactions using language. And then adaptation to change is the next one. I think this one's interesting because clinically, anecdotally, a lot of us know for our population, well, I'll start with, for the CARS, this higher scores typically indicates less flexibility, more challenges with adapting to change, greater difficulty with transitions. But actually, a lot of our scores on the CARS for this item are lower for a lot of our individuals with STX, because what we're finding is that our kids tend to be actually quite flexible and adaptive. And we're quite confident in that, and parents report that very often. So across sort of developmental level, we're pretty confident in that. So that's I just think an interesting point. That score's not a high score, but we're confident that that's typically falling at about a 1. Object use is another one relating to people. And then in terms of items we're less confident in, that includes from the far right, level and consistency of an intellectual response. This item is a tricky one, but really what it's interested in is peak skills. So we're looking for, in autism, it's common for some individuals to have these you're maybe delayed across the board, except you have a peak skill that stands out. And that's really what this higher scores indicate, more peak skills or a greater sort of discrepancy in your skills. And we're least confident, we found our clinicians were least confident in this item, partly because the assessment tool we use is not ideal for children with, we use the Bailey, right? So it's not ideal for motor differences, visual differences we've talked about. So we know there are a number of factors, thank you, influencing that. And then similarly, verbal communication, this is one that we know is impacted by motor differences, visual differences, and visual response is another one, and so on and so forth. So we're out of time. So just to close, we feel that it's really important to understand how to better identify and diagnose autism in the STX population. Understanding the nuances in autism individuals will help with more accurate diagnoses and ultimately lead to better and increased access to therapies and support. So thank you to everyone, and yeah, that's our team.
Thank you very much for the wonderful talk. About autism and seizure, I want to mention it's reported many articles, specifically one from Dr. Sheffer from Australia, that epilepsy itself, when it's uncontrolled, worsened autistic features over time. So depending if this cross-sectional or longitudinal, it may affect your score. That's one thing. And the other thing is, for example, we did this natural history study. If we do something more than CARS, or maybe CARS is also enough, I'm not sure about that, you can define a trait of autism among this patient. For example, Angelman syndrome. We see a lot of people, they are very famous for having laughter. They are very, happy looking, but they have autism. So they have a specific trait, but because it's a long time study about them, so it's known now. So I just want to say how you would address that, and is there any suggestion for further, kind of more detail? Or this is enough for, recognize that autism trait among STXBP1? Thank you.
Great points. I think that you're actually hitting on exactly what sort of our goal of this is, and this is just the beginning of looking at this data, but essentially we know that autism looks a little different in this population, and we're still trying to figure out how we can measure that. And so part of the goal of modifying the CARS and starting with confidence is to figure out if there's a subset of these items that maybe are more relevant to this group. They've done it, I think, in Fragile X too with the ADOS, which is another diagnostic tool, where they've sort of found a different cutoff is more relevant to diagnosing autism in that group. And so if that makes sense, the goal is to see, can we, if we're kind of defining the behavioral phenotype a little bit more in a unique way to this population, can we do that using the CARS? So that's what we're starting with. So we'll keep you posted.
And I would also add that anecdotally, and looking at the literature too, when parents describe their children to me, often their eye contact and social interest are two really standout features that, similar to kids with Angelman who are that, happy, smiley, these are some of the strengths that I often hear. And, that makes sense. Many children are impacted with, visual or, tremor, motor impact. So isolating a pointer finger may be physically impossible, but they do use that eye contact.
Hi, Andrea from Colorado. I think I was kind of thinking along the same lines, like in the end, is it possible that there's going to be like an STX? I'm looking over here because of the CCSA, like STSA, like an S cars or like something like that.
Yeah.
And so I wanted to know if the modified cars is that sent to all the sites? Is everybody doing that? Because your ends just looked a little smaller, but then I didn't remember the.
Let's talk, but
Cool.
but yes, they should be. But I don't think
Great.
we haven't. We'll talk, but yes, that is the goal: is for other sites to be doing it. Yes.
Hopefully, because it does seem like, or I guess I would just, I love that everybody's like talking about items today, because it seems like for this tool, you sort of need to use all the items together to use the existing scoring structure. But if we're just going to compile a newer group of items, then the more the better.
Absolutely, yeah. And we're still collecting it, and we also collect it at every visit with every participant until a diagnostic decision is made too. So it used to be that we did the cars once.
Just one time.
Yeah, and now because in a lot of times we were doing the cars and then it was like, well, they haven't reached the right developmental age, so that's the cars, and now it's like, well, let's keep doing it so we can collect this confidence and see confidence change both right across time within individuals and across the group. My goal is maybe we also sort of get to a place where we can, again, find an appropriate developmental cutoff for this group based on that as well. So
That sounds awesome.
Thanks.
I think this could really be impactful across disorders too.
thanks.
A
Yeah,
lot
I
of
think
our
in the
rare
profound
space.
autism world
Yeah.
too, especially. Yeah.
Totally.
Thank you.
Nice job.
Thank you.
Hi, I have kind of a general question related to these kind of severe neurodevelopmental disorder cases. Are you still interested in tracking like family history of autism? Is that something that's like prevalent among these populations, or maybe less so compared to other populations of autism with like lower support needs, things like that?
Definitely still interested. I'm not sure if we're tracking that. We are tracking that. Thank you. You're shaking your head, yes. I'm not sure where we are tracking that is what I meant to say.
Just as part of genetic counseling
Yeah.
evaluations and neurology evaluations, we always track family history, of,
right.
of neurodevelopmental disorder and autism too. So, and that's an interesting point. Thank you to whoever made it.
I do think it's an interesting point, and I do wonder about the differences in history, family history relative to like severity as well. So I think that would be an interesting question. Especially when there's a known genetic cause, and if it's a de novo, I think it has different implications. Thank you. Yeah.